All right, welcome back from lunch. We have a special guest, Dr. Roland Barrowman. You there, Roland?
Yes.
All right, excellent. Let me just do a quick introduction. If I may, Roland Barrowman is an Australian trained oral and maxillofacial surgeon, if I didn't screw that too badly. Roland completed his Bachelor of Dental Surgery at the University of Otago in New Zealand before relocating to Australia to complete his medical degree at the University of Melbourne. He was selected in the Victorian Oral and Maxillofacial Surgery Specialist Training Program in Melbourne and has worked in hospitals across Victoria. Roland is comprehensively trained in all aspects of the specialty and has advanced his skills with fellowship experience in complex facial injuries at the Royal Perth and Fiona Stanley Hospitals in Western Australia in 2016. He then relocated to the UK for further subspecialty fellowship training in head and neck oncology and reconstructive surgery at highly regarded units in Glasgow and Bristol before returning to Australia. He has also spent time in facial surgery units in the US, London, Singapore, Brazil, and Paris. Outside work, Roland enjoys being outdoors, traveling, experiencing different cultures and cuisine. Most of all, enjoy spending quality time with his wife and two daughters. Welcome, Roland.
Thank you.
Over to you.
Thanks, Ken, for that introduction. And thank you, Simon, for this opportunity. So today I'll be talking about orthognathic surgery. And as a bit of an outline, it's quite a broad topic, a very large topic. So we'll sort of be getting a bit of a flavor about the background, some of the common procedures and reasons why we need to do orthognathic surgery. I'd also like to share a few cases as well. And I'll be focusing the remainder of my talk about the surgical management of transverse maxillary deficiency and telengathic surgery for obstructive sleep apnea. So as we've been discussing with this group, has been very much about the growth modification and early intervention with treating dentofacial deformity. However, as we all know, as the patient gets a little bit older, we need to opt for other options, which can include orthodontic camouflage or orthognathic surgery in conjunction with orthodontic treatment. So in terms of treatment need, these are the patients with the skeletal discrepancies, which are severe enough. Just trying to get rid of this. Severe enough that neither orthodontic camouflage, growth modification would be able to provide the desired facial aesthetics and dental occlusal relationship and airway. And these are generally patients that we operate on when facial growth is essentially complete to allow the greatest post-treatment change. And of course, the patient has to have a desire to have orthognathic surgery in the first place. So let's see if I can get rid of this. We've got the screen issue.
It's looking fine. Everything okay?
I want to try and shrink down the panel on the side. Is there a way of doing that?
You mean on the panel with all the names of the panelists?
Yeah, it's quite large on my screen. So
you can, if you put your cursor on the very center where there's a double white line, you can drag it across.
Yeah, right at the border.
Yeah, it doesn't seem to be finding the cursor.
Right,
I'll press on.
Of the black and white, I guess, with your might help. Looks okay from our end, but
okay. So in terms of the objectives of orthognathic surgery, basically we want to address function in terms of occlusal stability, as well as periodontal stability. And of course, there's the issue of the airway as well, as we've been discussing a lot in this forum. And we also want to address the patient's aesthetic concerns, which is often their main concern. Orthodontic surgery is done with conjunction with an orthodontist oftentimes, and there needs to be decompensation of the occlusion. And this enables us to achieve a maximal amount of correction when we actually perform the orthodontic surgery. However, in selective cases that are more straightforward, a surgery first approach or surgery early on is possible, and this can have advantages. When we're thinking about orthodontic surgery, there are certain procedures that are considered very stable, and basically these maneuvers, they comply with the anatomy and they kind of make sense. So a maxilla going upwards, mandible forward, chin in any direction can be a very stable movement. However, when a mandible positioning further back or maxilla down, these movements can interfere with the airway and also the pterygomastoteric sling, and so they are considered less stable. So some of the common procedures that we have, these are the workhorse procedures, which include the Lefort-1 osteotomy. This is the maxillary osteotomy, and then we have in the mandible the bilateral sagittal split osteotomy and the genioplasty. Hugo Obergieser was the man who pioneered a lot of these modern approaches for orthodontic surgery, and he passed away recently in 2017. And I remember when I was a dental student, they had this book in the library on mandibular growth anomalies, and I was absolutely amazed by what could be achieved through orthodontic surgery and the procedures that was pioneered by Hugo Obergieser. And here we have a case illustration of a Lefort-1 osteotomy with the incision getting exposure to the anterior nasal spine and anterior maxillary wall. And we can see the infraorbital nerve on display there, and we can get very good access around the maxilla. Osteotomy is carried out in the anterior maxillary wall. We complete the natural nasal wall osteotomies with osteotomes, and we need to release the septum as well, and which can cause interference with repositioning of the maxilla. And here we can see at the moment of down fracture of the Lefort-1, and we can see the nasal floor above us, and further back, a very important vessel, the descending palatine artery and the nerve. And most of the time we try to preserve this nerve when we do the Lefort-1 osteotomy. And having freed up the interferences and mobilized the maxilla, we are now able to reposition it in 3 dimensions. So commonly we'll be moving the maxilla forward or moving up and changing. We're also able to change the midlines. And here's an intraoperative photo showing a maxillary impaction case of 4 millimeters. And in this case, we're able to use a saw to remove a 4 millimeter portion of bone and reposition the maxilla superiorly. So the maxillary blood supply in a Lefort-1 osteotomy, it relies in fact from the soft tissues around the maxilla and the palate. And so that comes from the ascending pharyngeal artery, which is a branch of the external carotid, and the ascending palatine artery, which is a branch of the facial. As you can see, after the Lefort down fracture, the nasopalatine artery is sacrificed, and oftentimes the descending palatine arteries are sacrificed as well. However, we do try to preserve that when we perform maxillary osteotomy, because the more blood supply is better. We're now looking at the medial aspect of the mandible, or the lingual aspect, where the inferior alveolar nerve enters the mandibular canal. And this is how the medial border, the medial osteotomy is performed. And looking at the lateral aspect now with the osteotomy along the external oblique ridge up to approximately where the lower 6 is. Inferior border cut going through there. And once it's performed on both sides, we are now able to reposition the mandible in 3 dimensions, whether that's coming forward or correcting midlines or asymmetries. Some intraoperative photos here showing the osteotomy on the lateral aspect of the mandible to the inferior border, and the repositioning of the mandible with a 10mm advancement with plates and screws. And a post-operative view here with maxillary and mandibular advancement with a good soft tissue profile result. Now, the other procedure, of course, is the genioplasty, and this is a very versatile procedure that we use for both aesthetic reasons, for vertical reduction, for example, for excessive lower facial third, or correction of anterior, posterior, or transverse issues. And it's also performed for functional reasons as well, to improve both lift competence and to normalize the soft tissue relationships around the teeth and provide stability. And of course, this is one of the procedures that can be used to improve airway in obstructive sleep apnea. As we all know, the genial tubercles here on the lingual aspect of the mandible is where the genioglossus and geniohyoid muscles attach. And so there's a possibility to advance those structures. Some intraoperative photos now with some of the modern plates that we use with a step. And this allows advancement of the genioplasty, and it's a very stable way of doing it. And using a different technique here, and with fixation and advancement of the chin in this case. Now, in the not too distant past, we used to do a lot of model surgery, especially for bimaxillary cases, and this was a particularly, we still need to do it, but it's quite a fiddly thing to do. And this shows the intermediate position that we need to bring the maxilla into with this would be for fabrication of an intermediate wafer. But luckily these days we're able to use virtual surgical planning, which is done with computer software, and we're able to customize plates and use cutting guides and wafers. And it's been a real game changer in terms of the ease of planning and both execution of the surgery. Piezo surgery is something that I use in my practice as well. It's as a morbidity reducing aid. It's certainly a lot safer to segmentalize around teeth using a piezo surgery as opposed to with a osteotome. So when we're considering some of the dentofacial deformities, this is from Posnick, but there are certain growth patterns that we commonly seen as candidates for orthognathic surgery. And these include primary mandibular deficiencies. So these would be like the class 2 patient, small mandible, weak chin, perhaps with submental fillness. And they often present with a lower facial third deficiency and a convex facial profile. And the mandible is such that it gives the illusion that these patients have like a large nose. And then we have the maxillary deficiency with relative mandibular excess. And these are the typical class 3 patient with speech and chewing and swallowing issues. And they often can be the candidates that we see as we've been discussing with chronic obstructive nasal breathing, which is commonly seen with this growth pattern. And they'll have that characteristic sunken midface, flat nasal base, and so on. And then we have the long facial growth patterns, vertical maxillary excess, and mandibular deformity. And these will often present with a lower excessive anterior facial height in the lower third with a gummy smile or anterior open bite. And a lot of this has to do with mouth breathing as well. And then we have the mandibular asymmetries, which can present with hemimandibular elongation or hemimandibular hyperplasia. and the short face growth patterns with maxillomandibular deficiency or with bimaxillary protrusion and dentofacial disharmony. So here's an example of a young lady with who's pre-surgery with a primary mandibular deficiency, class 2, very deep brachycephalic. And we can see that she has a diminished lower facial third. And with the advancement surgery, we have a much more pleasing aesthetic line and softening of the labiomental crease there with an increase in the lower facial third and a fairly stable result overall. Class 3 case, this young lady underwent a surgical maxillary expansion prior to bimaxillary surgery to correct her class 3 with a relatively deficient hypoplastic maxilla. And it's really nice to see these patients as when they come back to the office. Yeah, they sort of, after the surgery, they become more sort of confident, and yeah, this young lady had a good result. And just taking you through their virtual surgical planning now, you can see that she's had the expanded maxilla. If you look closely, you'll be able to see that she's had maxillary expansion, Lefort 1 previously. The planned position of the maxilla, bringing it forward 5 millimeters, and a very small mandibular setback to go with it. And we can also predict the soft tissue changes as well using the software. And we can see that she's had a good result from that. And another class 3 case, young lady, and we can see she's got the deep labiomental fold and a very long lower facial third. Computer planning, maxillary advancement. This is the intermediate wafer that is used. So maxilla first approach, mandible to fit. And it's very useful with the planning software. We can see where interferences are potentially going to be, and this can aid us during the actual surgery, especially where there are minor asymmetries. There tend to be interferences that need to be dealt with. And we plan for a small reduction, genioplasty advancement for her as well. And this was the final result there on the X-ray and the preoperative plan position. And you can see the changes in the soft tissue profile. And she was very satisfied with her result. This next case is a vertical maxillary excess. So this is the long face individual. She had a history of chronic obstruction and nasal breathing. You can see she was probably one of the most marked vertical maxillary excess cases I've treated. And we planned for a 8 millimeter impaction there. And we have to warn the patients beforehand that there can be some nasal changes in terms of nasal widening, and we try to minimize this with maneuvers on the piriform aperture, turbinoplasties intraoperatively, and septoplasty. But sometimes we may need to consider other options as well, such as alar wedge reduction, referral to peri, for example, to address any issues. And we can see that she's had a nice result there with good lengthening of the mandible, because with the impaction of the maxilla, what tends to happen is that we get a counterclockwise rotation of the mandible, which equates to a pretty significant advancement in the mandible, as you can see here. And we have a mandibular asymmetry case, class 3. Young lady here, and she's got a 4 to 5 millimeter midline shift to the left-hand side, which you can see most obviously on the PA radiograph of the skull. And we're able to get this result with correction of a midline, a mandibular midline, with maxillary advancement and mandible to fit, and correction of their midlines. But not all mandibular asymmetries are so straightforward, as in this gentleman who was in his 30s and he had a progressive malocclusion of class 3, which occurred over the past few years. And on further investigation, it turned out that he had a large active osteochondroma pathology in his left temporomandibular joint, and it was occupying much of the infratemporal fossa there. So I went ahead and this shows that the orthodontic procedure can be combined with TMJ procedures as well. And this is a patient-specific total mandibular joint replacement. And the osteochondroma had to be removed piecemeal because it was quite large. And the access, as you can see here, is quite small. And in this image, we can see the custom prosthesis in place. This is the Orthotin prosthesis, which is from Canada. It's quite a good prosthesis. And the post-operative CTs, rendered CT scan here, showing the total joint prosthesis on the left-hand side and sagittal split osteotomy to bring the occlusion in. And a post-operative photograph showing that he has good facial nerve function. And of course, mandibular asymmetry, there can be hemimandibular hyperplasia cases, such as in this young lady with her chin deviation to the left-hand side, and she's got an open bite on the right. We can appreciate that more vividly from the inferior, from the worm's eye view, showing the excessive growth on her right hemimandible, which corresponds with her CT scan. And we can see that on her OPG as well, with the increase in the height of the body of the mandible on the right-hand side. All right, so are we going to do any questions at this stage, or should we keep going straight into it? Is anyone there?
Roland, thank you for sharing that. The question is, a lot of surgeons in the past used to shy away from TMJ replacement with a prosthesis. Is that becoming better controlled with the CAD custom appliances?
Yes, yeah, you're absolutely right. In the old days, TMJ surgery, there was a lot of scielastic implants and things, and they didn't do too well. But certainly with today's technology, with the custom prostheses that we're using now, we're getting very good long-term results. And they can last for a very long time, like 20 years plus. The TMJ concepts has been around the longest time, and yeah, and oftentimes there's been a shift to sort of like earlier definitive management with a total joint replacement, as opposed to some other procedures such as discectomy and fat grafting and things like that.
And a lot of the literature that I went through was from Larry Walford, who was one of the...
Yes, he's a very prominent figure, yes. He gets some amazing results.
Yeah, he attributes his success to dealing with the joint first before dealing with anything else in the...
yes, and that makes sense.
Yeah, very good to see some positive changes.
So this next section of the talk will be on surgical maxillary expansion. And this is the scenario that we're talking about. You know, chronic nasal breathing, transverse maxillary discrepancy, maxillomandibular discrepancy with a buccal crossbite. And, yeah, as we're all aware, their tongue position plays a significant role in this. So with mouth breathing, the tongue doesn't have an opportunity to stay up in the palate, and these individuals will develop a very narrow maxilla. So the aims of increasing the dimension of the maxilla is to alleviate crowding, correction of the crossbite. And we often do it in Melbourne. It's kind of thought of as the Melbourne way of doing things with bimexillary surgery, is to do a maxillary expansion first surgically as a prelude to further orthodontic surgery. And certainly from a surgeon's point of perspective, there's advantages to that, as it avoids segmental maxillary surgery, which is a lot more complicated. And it creates more room for the tongue as well, and of course improves the airway. So yeah, once a patient reaches maturity, there may be difficulties at removable maxillary appliances in terms of inability to activate the device. There may be buccal tipping of the teeth, bending of the alveolar bone, and pushing teeth out of the alveolar envelope, resulting in gingival recession and other issues. So when we look at the history of maxillary expansion, I'm sure we would have mentioned Engel was back in 1860. He was ahead of his time, and he used a palatal screw to widen the mid-palatal suture. And since we've identified areas of resistance in the facial skeleton, which has helped us to develop the current technique. So when we consider the important buttress is the zygomatico-maxillary buttress, which needs to be addressed. In addition to the osteotomy down the midline and the mid-palatal suture. And the benefits of surgical assisted maxillary expansion, improved nasal flow, elimination of dead space, and it fills out the buccal corridors, so it has an aesthetic advantage there. It avoids tooth extraction for alignment of teeth. And we're able to widen the arch and correct posterior crossbite where no further orthodontic surgery is planned, and to provide space for crowded anterior teeth as well. And as I mentioned, we often do this in Melbourne as a preliminary procedure where further orthodontic surgery is planned. And it avoids the inherent risks with segmental surgery. And where the expansion is greater than 8 millimeters with a segmental, there can be issues with stability. So indications for a SAME include maxillary hyperplasia with mandibular width excess, failed RME, transverse maxillary deficiencies of greater than 5 millimeters in skeletally mature patients. Orthodontists can probably camouflage discrepancies up to 5 millimeters. Where there's greater than 7 millimeters of surgical expansion required. And the alternative to, sorry, there's a bit of echo there, to a surgical assisted maxillary expansion is the segmental Lefort one, as we can see illustrated here. And basically what is involved with this is a U-shaped osteotomy over the hard palate, and the maxilla is segmented, as you can see here, in 3 pieces, and it is a good way of dealing with a biplanar occlusion, for example. And the indications for this would be, again, maxillary hyperplasia, where there is a transverse discrepancy with a biplanar occlusion, or patient with a moderate discrepancy. And certainly from a psychological point of view, from a patient's perspective, it's kind of easier to digest having one surgery as opposed to having to have 2 orthodontic procedures. And where there's a significant curve of speed, there can be advantages to using a segmental surgery to help level the occlusion, or a failed surgical maxillary expansion. So when comparing the surgically assisted maxillary expansion with the segmental or 4-1, it certainly is technically easier to do the surgical maxillary expansion, and more difficult and technically challenging to do a segmental or 4-1. With the same, we're able to do bigger expansions, whereas the segmental, we're limited to 6 millimeters. The advantage of the segmental, of course, is we're able to address changes in the occlusion by planar occlusion. And depending on who you read, both can be very stable. I often find that it's a lot of it has to do with the orthodontic setup, with the stability, with segmental surgery. And relapse can be an issue as well. So obviously with a same, the treatment time is a lot longer, and with a segmental or 4-1, everything's sort of done in one hit, and the patient goes through the recovery period. So, but in terms of complications, comparing the two, there certainly is a higher risk of major vascular issues with the segmental surgery, including significant bleeding from the greater palatine vessels, avascular necrosis as the segments are segmentalized, has to be done very carefully with preservation of as much of the soft tissues as possible. And of course, tooth damage is possible in both cases. So with surgical assisted maxillary expansion, this is actually an example of distraction osteogenesis, which is creation of new bone in an enlarging gap between two bone segments. And this is in response to tensile force across a bone gap. And with the addition of new bone, we're actually getting distraction histiogenesis as well. So we're actually getting more soft tissue and more vasculature and lymphatics come into the area as well. Elizarov was a Russian orthopedic surgeon back in the 70s and 80s who pioneered this treatment for long bone traumatic injuries. And he came up with certain principles that dictated how it is done, and certainly rate and rhythm are important considerations. And we don't want to be distracting the bone too fast, otherwise there's risk of thin bone, the bone being too thin, or there being non-union. And then there needs to be a good period of consolidation. You can see here with this long bone, the device, distraction device or transport distraction will be left in for a period of time. So with our surgical assisted maxillary expansion, there are 3 phases of distraction, which include the latency period, which is immediately after the osteotomy is performed, to activation of the distraction device. And generally speaking, we allow 5 to 7 days for hematoma and granulation tissue to form before we actually apply the distraction. And this seems to be one of the measures that we can utilize a decent, an adequate latency period before activating to prevent endodontic complications with the central incisors. And subsequent to the latency period, we start activating the appliance, and that is turning the screw, which is in the device. And generally we go for 2 turns, which ends up being 0.5 millimeter today, until the regenerate forms along the mid-palatal suture line. And then subsequent to this, there's a consolidation phase after distraction is completed, and this allows for calcification across the gap, and the distractor is kept in place, which can act as a scaffold. It's generally done as a day procedure or as a 24-hour stay procedure, and the device needs to be fitted prior to surgery by the orthodontist, and the patient is educated on how to use the device, the expansion key. And we also counsel the patient to expect swelling, bruising, paresthesia. They may have a blocked nose, epistaxis, bleeding nose, or other surgical risks. Some of the complications that we can see with this treatment is asymmetric expansion, which can be correctable by orthodontic correction or further surgery. It can be infection, bleeding, nasal changes, although they're not really significant. And oftentimes these individuals have a very narrow nasal base to begin with, and they can actually benefit from both form and function in terms of the nasal changes here. And there's a potential for paresthesia in the infraorbital nerve distribution, which tends to be temporary. There's no significant maneuvering of displacement of the nerves in this case. And of course, we've talked about endodontic potential complications with the central incisors. So I'd like to show you a few slides here of an operative case. That's the hyrax, which has been fitted previously. The Lefort 1 osteotomy, in this case incorporating the maxillary canines for exposure. I generally don't do incisions this broad anymore, but here we can see quite nicely extension out to the posterior maxilla, the piriform aperture on view there. And then the Lefort 1 osteotomy is completed with a saw, with a micro saw. And at this point we start to activate the appliance. So we give it 10 turns. And so that creates tension across the maxilla. And before we go ahead and do a midline osteotomy, and in this case we're using osteotome, so we get that going between the two central incisors. And we can now see a gap opening up because the appliance has actually been activated already. And we can see blanching of the tissues. And at this point, what we want to look for is independent movement of the segments to confirm that that's going to happen. And these days, this is the technique that I'm using. It's published by Hernandez Alfaro. It's a small incision in the anterior maxilla. It's about 2 centimeters. But in using this, able to get back behind the maxilla, perform the down fracture, and the only difference is I would use a piezotome down the midline, which I feel is a safer way of avoiding vascular injury to the central incisor. So it can be done either as IV sedation or general anesthetic. I tend to do it as a day case, and certainly has reduced morbidity with a shorter intraoral incision with more blood supply to the vestibular mucosa. So I wanted to talk about distraction osteogenesis, maxillary expansion. Recently, we had a integrative meeting on obstructive sleep apnea held in Melbourne, and we were visited by Stanley Liu from Stanford University, and this is where I met Sun Wong originally. And one of the procedures that was talked about was distraction osteogenesis maxillary expansion. And so again, this is for the high arch palate, narrow maxilla phenotype. And as we've alluded to already, these individuals have a high risk of obstructive sleep apnea. And although this expansion of the maxilla has been in the past done for the sake of dentofacial deformity, we know that in the pediatric population, of course, obstructive sleep apnea can be alleviated with RPEs. So with maxillary constriction, there is increased nasal resistance. These individuals will snore more. There's no space for their tongue to occupy their hard palate. And they'll have an elevated nasal floor as well, which all is contributory to a poor airway, as the tongue is more posterior displaced as well. So this concept of palate-borne distractors is not a new one. Probably the first variation of this was described by Momarts, who's a maxillofacial surgeon from Brussels in 1999, and he developed palate-borne distractors with the advantages that it eliminates tipping forces on the teeth, which can happen with a hyrax, which is generally used, and active alignment is possible at the same time with the expansion device in place. So we can see here, these are the KLS Martin distractors. They're very expensive, but yeah, they have the advantage that they don't engage the teeth at all. And with the dome technique that Dr. Stanley Liu is advocating is with 4 mini TADs with a palate-borne distractor. So the dome technique is a single Lefort 1 osteotomy with a anterior mid-palatal suture separation assisted by bone-anchored device with 4 TAD screws. And with this procedure, there's a potential for more targeted expansion across the palate with widening of the internal nasal valve. And this can contribute to patients' perceived improvement in their airway and improvement in their obstructive sleep apnea as well. So here's an illustration showing the V-shaped maxilla and being expanded using the 4 mini screw retained maxillary expander along the mid-palatal suture line. And with the protocol here, the expander is kept for 8 months, 6 to 8 months after the surgery. And here we can see from one of Liu's papers that the advantage of these palate-borne distractors is that it's the vectors applied across the mid-palatal suture line is right on it, so as opposed to where the teeth are, so you get less tipping forces applied to the posterior teeth there. And there's a potential for maximal distraction across the mid-palatal suture line. And here we can see fitting of the maxillary expansion device, an intraoperative photograph showing the technique and what is possible after the activation period and with alignment of the teeth. And this patient will now have a very nice broad arch, plenty of room for the tongue, and there's potential for improvement in the airway as well. And another case from the Stanford group as well, showing the distraction healing across the mid-palatal suture line and after alignment of the dentition. And from the anterior aspect as well. So it seems to be a very good way of approaching the issue of transverse maxillary deficiency. And in Audrey Yoon and Stan Liu's paper, they saw an alleviation of nasal obstruction, increased AHI scores, improvement in the quality of their sleep. And they recommended this as a targeted intervention for particular adults with this phenotype of a narrow maxilla and obstructive sleep apnea. Now, there's a concept of the internal nasal valve, which I'm sure Perry will be able to advise us on during his discussion. But in a Caucasian, it's considered to be this nasal valve angle is between 10 to 15 degrees. And a lot of dentists with an interest in airway will be aware of this. This is the Cottle's mover, basically lateral pressure over the mid-cheek area and sniffing. And if there's alleviation or improvement, that's a Cottle's positive test. And so that suggests there may be some collapse of the external nasal valve. Traditionally, this is in the area of rhinoplasty surgeons such as Perry. This would be treated with strut grafting, which you can see here changes that angle of the internal nasal valve. However, as has been shown recently with Stanley Liu's group, there is improvement with the internal nasal valve and surface area overall with the dome procedure. And it kind of makes sense because the base of that triangle is expanded with the expansion of the palate and nasal floor. So the dome procedure improves the the outcomes and the specific phenotype as we've discussed, with improvement in the internal nasal valve angle and valve surface area. And these patients will have perceived improvement in their nose scores as well, with reduced severity of obstructive sleep apnea and better quality of sleep. And do we have any questions so far before we go into the final part of my talk?
Yes, Roland, with one of the things that Stanley Liu pointed out, which I think we're in agreement on, is that not only is the three-part segmented approach more dangerous for the patient, but we get a significant the lower level of improvement in the tenting effect of the oral pharynx and the soft palate.
Correct.
One of the things that you highlighted to me, which I never really understood, and hopefully you can explain to the doctors on at the moment, is that in a three-part, you leave behind the posterior part of the maxilla, right?
It depends. Yeah. It depends where the pterygoid is separated. So oftentimes we try to avoid putting an osteotome through that junction because it tends to bleed a lot. And so we try and bring that just anterior to it. But certainly from the point of view of fixing discrepancies in the level of the occlusion, where we have their focus on the dentition, the occlusion only, the segmental surgery can be a very good option for addressing those issues. But perhaps from an airway issue, there's less of a potential for that improvement in the lateral pharyngeal airway. However,
So
having said that, if we're advancing the maxilla as well, there's potential for improvement. And also having a wider maxilla creates more housing for the tongue, which is going to be beneficial from an airway perspective as well. So I think potentially we can see improvement with segmental surgery as well from an airway perspective, but yeah, certainly the dome procedure, because of that distraction histiogenesis and broadening across the nasal floor, it makes sense that there's advantages to having that approach.
I think Nathan had a comment. He wrote,
Yeah.
what do patients notice with the dome anchors from a nasal perspective? Anchors appear like they pass through the floor of the nose.
I haven't had experience with the mini screw retained maxillary expanders. I've done more sort of like the conventional Hyrax. I have used that palate-borne distractor that I showed you. But yes, that is a valid comment, that there is a potential for the screws to go through the maxilla, through the palatine bone, which is very thin. But what I would do in that case is I wouldn't select a screw that is too long. And also there is a potential for using your cone beam CT to plan where the mini screws can go as well, to engage the thickest portion of the bone.
Yeah, definitely
But the patient's probably not going to feel it very much, to be honest. If it's a short screw, fairly short screw, that doesn't, obviously you wouldn't be putting a 10mm screw through the palate there. You know, it'll be something more like 4 to 6mm.
He's got a follow-up. In a Lafort, are you able to avoid the maxillary sinuses in all cases, or does it matter if you cut through it?
In all Lafort osteotomies, we're cutting through the maxillary sinus. Yeah, there's no way of avoiding that. That's part of the procedure. But what I do try to avoid is violation of the nasal mucosa. So I sort of take my time around the piriform aperture, very carefully try and dissect that off, because it can lead to a lot of bleeding intraoperatively, which is problematic. And certainly with considering a day surgery procedure for maxillary expansion, you know, what you want to have like a dry field and the patient not to have to stay overnight unnecessarily. So yeah, we do try to avoid violation of the nasal mucosa, but again, it's not always possible. But we always go through the maxillary sinus with the Lafort 1 osteotomy.
Okay, I think we can have you continue.
Right. So for this last part of the talk, I was going to discuss some of the maxillofacial interventions for obstructive sleep apnea. Now, obviously, we've already talked about maxillary expansion, but over recent years, we've seen an increase in obstructive sleep apnea as a worldwide phenomenon, and increased prevalence in adults ranging between 9 and 38%. And with this, we're seeing an increase in obesity rates, and there certainly seems to be a bidirectional relationship of obesity and obstructive sleep apnea with long-term complications. Some of these complications can include a diminished quality of life. They'll have now loud snoring, and so it affects their personal life with their partners. They have poor concentration at work and sleepiness, and they can be a motor vehicle accident risk. Their risk increases 7 times, and they may have depression or irritability and be at risk of stroke and other complications such as cardiac disease, metabolic syndrome, and so on. So some of the conservative therapies that you'll all be aware of include good sleep hygiene, lifestyle modification, trying to lose weight, exercise, avoidance of alcohol, cigarettes, sedatives, and avoiding sleeping on the back, so adopting a lateral sleep position. Some of their non-operative interventions include CPAP, which is considered the gold standard. There can be issues with compliance, and the patient needs to wear this for the rest of their life. Mandibular advancement devices as well. There can be issues there with comfort, and then it's very difficult to make for a edentulous patient, for example. And then there are the tongue reposition devices, Snorex, positional therapy, and a very cheap intervention, mouth taping. So the surgical options can be divided loosely into some of the more soft tissue procedures traditionally done by ENT surgeons, and then the skeletal surgery traditionally done by maxillofacial surgeons. And from the soft tissue surgery procedures, there's probably more than 20, but I've listed a few here. And looking at the skeletal surgery, we've talked about surgical assisted maxillary expansion and dome. And there is also a genioglossus advancement and maxillomandibular advancement. And here is an example of a genioglossus advancement, which is basically trying to engage those genial tubercles that attach to the genioglossus and geniohyoid muscles, and creating a window and pulling that bone forward with the muscle attached to it and repositioning it. And here it's shown combined with a hyoid suspension procedure. And often this procedure would be combined with genioglossus advancement, but it probably has probably not that satisfying results compared to maxillomandibular advancement. Maxillomandibular advancement is now widely regarded as a very effective surgical means of engaging the nasopharyngeal, oropharyngeal, and hypopharyngeal airway, and it helps to expand the facial skeleton, so effectively increasing the housing of the airway, increases the soft tissue tension, and decreases the collapsibility of the airway. And from a meta-analysis by Lee, there was a 86% success rate. And And the reason for this is that obstruction in obstructive sleep apnea often occurs at multiple areas, especially in an obese patient with a skeletal deformity, which would explain relative lack of success with more isolated procedures such as UPPP. So there's been a bit of a shift in the treatment paradigm with maxillomandibular advancement. It's traditionally considered more of a last resort, but now there's been more of a case as more of a first-line intervention, especially in a younger patient who's not obese with skeletal disharmony requesting aesthetic improvement. And the huge advantage here is that the patient won't have to have CPAP for the rest of their life. And Stanley Liu mentioned when he visited Melbourne that there's been a revision in the Stanford protocol, and they do, so they consider maxillomandibular advancement much earlier, and they'll jump to that, and also maxillary expansion with dome. So is maxillomandibular advancement a last resort or permanent treatment? We will see that in select cases it can be a permanent treatment. And the categories of patients that we commonly see, there are two groups. There's the younger patient who wants to have successful treatment and they don't want to be dependent on CPAP for the rest of their life. And then we see, on the other hand, an older patient who may be over 55, having problems with their CPAP and appliances. And they come in, unfortunately, with other comorbidities and may have had other surgery, but still feel very tired, can't stay awake. And they basically want to undergo surgery because they're very miserable and tired. So here we can see an example from Posnick's book with the younger patient scenario with the hypoplastic mandible and displaced tongue to the oropharynx, and following maxillomandibular advancement with counterclockwise rotation, we can achieve good opening of the airway at multiple levels. And again, with the older patient, maxillomandibular advancement surgery can be done as well. However, this patient will come with more comorbidities. They may have had a lot of other interventions as well. We often try to combine maxillomandibular advancement with orthodontic treatment, and that way we can improve or maintain their preoperative occlusion. And it also gives us a chance for the orthodontist to give us hooks on the teeth, which helps with intermaxillary fixation. And we're able to eliminate compensations as well. However, with maxillomandibular advancement surgery, oftentimes these patients are very keen to crack on with surgery, and we often do this as a surgery first, or at least a surgery early approach. So maxillomandibular advancement, as we've mentioned, is one of the most effective surgical procedures for obstructive sleep apnea. And in fact, it is the most effective procedure after doing a tracheostomy, which would obviously bypass all the airway, but have practically zero patient acceptance. Original protocol was advised by Ridley and Powell, which advocated a 10mm advancement in both maxilla and mandible. However, this can lead to aesthetic changes which may not be so desirable, especially in the paranasal region. However, there's a very high cure rate quoted in the literature, or improvement based on AHI. So the anatomical basis of maxillomandibular advancement is that it improves the dimension in both anterior, posterior, and transversely of the pharyngeal wall muscles. The mandibular advancement itself pulls the tongue off the pharynx and takes with it the anterior belly of the digastric, mylohyoid, genioglossus, and glenohyoid, which helps to open up the airway. And the Lefort 1 advancement, of course, will also distract the tissue of the palate forward and open up the airway and pull the palatoglossal muscles up. But we need to be a little bit careful with thought on advancement, is there can be issues with nasopharyngeal incompetence, especially in patients who have had like very aggressive palate surgery in the past. So the maxillomandibular advancement can be considered for patients who have had successful treatment with oral appliance therapy or CPAP or wish to have a definitive solution, or for those patients who have had compliance problems with CPAP or oral appliance therapy. So it's considered a safe and effective treatment in a systematic review by Holte and Guilleminol in 2010. It was determined that for surgical success, it's better to operate on younger patients with a lower BMI, with lower comorbidities, and a lower preoperative AHI. And it was seen that greater improvement with the airway was seen with a greater maxillary advancement, with 86% success and a cure rate of 43%. So if we were to pick our winners, we would like to consider a younger patient with maxillomandibular deficiency, lower BMI, and lower AHI to begin with. But a little bit circumspect with older patients who may come with more comorbidities, more adiposity, especially around the neck and tongue region. And they may have had previous multi-level surgery with scarring across the palate and so on, and higher BMIs. So some of the risks associated with MMA include prolonged stay and complications in the hospital, and we need to consider that with the more older patient group. There may be unsatisfactory changes with the face, but as a general rule, if they've got a skeletal issue in the first place, advancement of the maxillomandibular complex will result in favorable aesthetics and function. There can be persistent anesthesia as well, with occlusal disturbances as well. And the patient may need to be in hospital for two days, which is a general time frame for double jaw surgery, to 1 week in hospital. So here we've got a digital planning for orthodontic surgery showing these are cutting guides manufactured that help to determine where to place the osteotomy, so we can do things very predictably. And these customized plates can be fabricated, advancing the maxilla into the new position. Genioplasty surgery as well, with a plate, patient-specific plate, relocating the genioplasty segment anteriorly. And we can predict the soft tissue and also the airway changes with 3D planning. And with maxillomandibular advancement, there can be an advantage with this particular alteration of the maxillomandibular complex, which is a counterclockwise movement. And here we can see a cutting guide, which is manufactured where there is a wedge taken out of the lateral aspect of the piriform aperture there. And what this allows is, with advancement of the maxilla, a counterclockwise rotation in the complex as well, which equates to a more exaggerated movement in the mandible. So say, for example, a patient who has a 6 millimeter advancement in the maxilla might end up with a 15 millimeter advancement in the mandible. So the counterclockwise rotational advancement is an advantage because it minimizes the paranasal distortion in those select cases. The way we do this is we do a osteoplasty of the anterior nasal spine and hollow out the piriform apertures. Outfracture of the turbinoplasties can be applied as well, with the net effect of elongating the mandible and with elevation of the genial tubercles. So this serves to accentuate the jawline, lengthen the chin-throat distance, and it sort of has a reverse facelift effect in some of these older patients, adult patients. And this was taken from a recent article by Hernandez Alfaro and al. And this is showing an adult patient undergoing counterclockwise movement with a good sort of elongation of the mandibular jawline aesthetically, and in terms of function, there's a significant improvement in her airway. So in conclusion, maxillomandibular advancement there can be considered as a first-line treatment for say, younger patients who are non-obese with skeletal maxillomandibular discrepancy, desiring aesthetic improvement. Thanks for your attention.
Oh, terrific. Roland, thank you so much. Got plenty of time for Q&A, looks like. Another 23 minutes at a schedule. Meadle has a quick question. With regards to MMA success, is that defined as AHI of 5 or less, or reduction of AHI by 50%?
It's reduction of AHI, yeah. But in a select number of patients, there may be the potential of them not needing CPAP anymore. Yeah.
Okay, Meadle, does that answer your question?
Yeah, sorry. Hi, Roland. Thank you. Amazing presentation. So is it a reduction by 50% or more than that?
Yes. Yeah, a reduction by 50%, I believe. Yeah, more than that. Yeah.
Okay. All right. Thank you.
I need to check the exact figures and get back to you. But,
no, I was just curious because, I mean, because it still has that. I mean, I guess you could still have people who have an AHI of 60, and then if you reduce that by 50%, they're still in severe sleep apnea, technically.
Yes.
Yeah.
Yes.
Okay.
So can be a significant improvement. I mean, cure is quoted in the literature as being around 43%, with success being improvement in AHI as 86%.
Awesome. Thank you.
Welcome.
Brian, you want to unmute and ask your question? Brian writes, is there an issue doing MMA in conjunction with aligner orthodontics compared with fixed brackets?
There's certainly advantages for doing bimaxillary surgery with aligners. Yeah, I mean, certainly in terms of cleansability of the area in the wound, this tends to be better. I haven't had a lot of experience with that, but yeah, it certainly can be done with aligners. But in that case, I would use skeletal anchorage with IMF screws in conjunction.
I might jump in on that one. We actually have another guest, Dr. Sandra Card. So she has popped in, and she's been in a very fortunate position where she's worked. Hello, Sandra. How are you?
I'm good. Thank you for inviting me. This was a very nice presentation.
Thank you.
Thanks for joining us. So the question was whether Invisalign can be used in conjunction with the orthodontic procedures. And she's been in a very fortunate situation to have worked with Professor Alfaro Hernandez, who has operated on fairly routine basis where the orthodontists have set it up in Invisalign, as well as working with Stanley Liu, who prefers fixed braces. So maybe Sandra can chime in on this.
Sure. Thank you for the privilege to participate. I am currently waiting to have my own surgery, and I'm wearing aligners. So I'm a little biased towards the therapy with Hernandez Alfaro because he puts some screws TADs, 4 TADs on each side for elastics after the surgery. But I do think with Invisalign, the orthodontist, I mean, I've set up so many cases in my older practice with brackets, and it was always a hit and miss. And the protocol was a year before treatment, then the surgery, then a year after treatment. And the few cases I've set up, only 3 cases really, with Invisalign, and you can do all of that before you even start, because you can do the surgical jump in the software. And I'm privileged to have Simon help me and set up the case so that right after surgery, the case is really solid. So in the case of my daughter, she had the TADs and she was supposed to wear the elastics, but when she went to her post-op one week after the surgery, it wasn't really even necessary to wear the elastics because the bite just fit so nicely. And through Simon's protocol with the GoPex exercises, the patients, you know, they're working out the tonicity of the muscles to be able to hold that bite. So in her case, after 1 week, Dr. Alfaro said, you don't really need the TAD. So he removed them a week after treatment. So she really never even used the elastics, because with Invisalign, you can get the bite so solid. And in addition to the GoPex program, you can get the patient's muscles prepared to hold that position. So in the 3 cases that I've done with Invisalign, it's been, excellent. But, you know, the protocol for Stanley Lou, I think, is still full braces so that they can have stability after treatment.
It's all about, a lot of it comes down to the orthodontic setup, I believe.
Absolutely.
The stability, the occlusion.
And I don't know if anybody hearing here is one of Dr. Wong's mentees that he's mentored. But if they can get any surgical case to be, thought of by Simon, by Dr. Wong, I think it's worth it, because he really he's like a chess player that can imagine what the case will look like. And he can really set up things so that the post-op it's more successful.
Yeah, it's interesting you say about the GoPex. That's something that's really intrigued me about orthognathic surgery cases, especially in these patients who may have had a breathing issue to begin with, a mouth breathing habit. It's certainly worth looking into retraining those jaw muscles and breathing patterns to maintain the stability, I believe. Yeah. But I haven't seen a lot on it in the literature about its utilization in orthognathic surgery.
I think a lot of it is Brazilian, a lot of Brazilian research.
Yeah, that's what I noticed actually. So I couldn't
But
access
Dr.
it.
Stanley Lou is very interested in utilizing Dr. Wong's protocol. We had a meeting earlier this week, and he sent me an email saying, please take us on this ride. And, Dr. Wong's article that we published together in Bioscience, I think a lot of people are starting to look at the stuff that he's doing as the new standard of care. And Dr. Lewis definitely has Dr. Wong on his radar now. So I think we're going to do a lot of things with GoPex and GoFex, which are these two exercise programs.
Fantastic.
I think there was another question from Mital about neuropathic pain and relapse issues with MMA.
Yeah, so clearly, relapse can be an issue. But one of the advantages, I sort of didn't touch on it during my talk. I mean, some of the movements, such as the counterclockwise movement, can be considered less stable because it sort of goes against the pterygomasteric sling. But there are a lot of prominent surgeons, such as Renicky, Hernandez Alfaro, who use these movements. And with the modern sagittal split technique, that's less of an issue, but also with regards to modern plating techniques, it helps to mitigate a lot of the relapse as well. And I don't know if you can see that, but that's a maxillary plate, which is custom fitted. Just try to, maybe I'll stop share. I can't really do it from here. Yeah, so what helps with that is the customized plates. They're very rigid, and yeah, there certainly can be issues with relapse. And working with an orthodontist helps, and establishing a stable occlusion helps to mitigate some of that relapse, because these are big movements as well, with distension of the soft tissues. And with regards to neuropathic pain, that can be an issue as well. Potential risk with a maxillomandibular advancement surgery. I don't tend to come across it very often, even in a lot of my adult patients. Certainly paresthesia of approximately 20% can be an issue, but overall, I believe these obstructive sleep apnea patients, they're very desperate a lot of times, and even if they ended up with an area of paresthesia, that would be a small sacrifice to them for significant improvement with their sleep and feeling refreshed and just in general.
Could I ask? Sorry,
answers your question.
I was just wondering. Sorry, could I ask one more question? Would you recommend MMA as a first-line treatment for someone who has moderate sleep apnea, or is it only for the ones who are in the more severe category?
I would potentially offer it for someone in a moderate category, especially if they're younger with a definite craniofacial issue. That can be rectified. Yeah, so I think generally it's kind of better to operate on patients when they're younger, right? As opposed to later on in life when they've got more comorbidities. If someone is over 55, for example, I would say to them, look, you're definitely going to be numb, whereas you can have a completely different conversation with a 30-year-old and about that potential risk.
Thank you.
Cheers. Cheers. Me too.
Okay, another question from Damien. Hi, Roland. Thanks for the talk. How much does it roughly cost for a patient for an MMA and dome surgery?
Dome surgery? Yeah, well, roughly, it depends if they have private health insurance, but roughly for a dome would be about $2,000 for the actual surgery. And then there will be the hospital costs and anaesthetist costs as well. MMA surgery, roughly $7,500. Yeah, I mean, fortunately today with the technology, it allows us to do surgery much more efficiently than in the past. So one of the deciding factors, of course, with giving a quote for a patient would be whether or not they have private health insurance. But those figures that I quoted are rough figures for Melbourne, but I believe that interstate, the cost for an MMA could be astronomical, for example. But as an approximate, that would be approximately 7 to 8 for MMA, 2,000 or so for dome procedure in terms of surgical cost.
It's quite amazing. It's quite amazing looking at the technology available with the surgical cut guides and the planning. We see how you guys can plan the movements and then build the customize the cut plate so that you bolt it in place so that you cut along the dotted lines, and then change over with the bolts so that you've got the movements predetermined and set. I can't imagine, the older surgeons like Walford and Hernandez in the earlier days when they just did it by hand-eye coordination.
Yeah, we used to do that not too long ago, actually. So, yeah, the technology has exploded, like in terms of, just better understanding the applications and so forth. Yeah.
And that must reduce the predictability of the movements, and the careful planning and the avoidance
Absolutely.
of all vital structures
Yeah.
must reduce the risk level of relapse for the MMAs, and
Yes.
make them more accessible for a broader range.
It's made it more predictable, and like in the old days, we had to, we're relying on seating of those intermediate splints. We're also trying to get a reference point, so we'll often use a K-wire, like right in the nasion area. So we don't need to do that anymore. With the plate, we can basically move the maxilla relative to itself after doing the osteotomy. So it's certainly simplified surgery a lot more. Yeah, in terms of the time factor and predictability, stability, and so forth.
And then Sandra, when we were chatting with Stanley Liu earlier this week, he mentioned that his preference now is to start with the dome, get the maxilla developed, and then move it as one piece. And again, that reduces the risk of the complications of the three-part, but allows him to do a much more aggressive MMA. Moving three parts and then worrying about the structures limits you a lot more.
Oh, absolutely.
I was talking to Dr. Perez Varela just yesterday, and the way it's done in Spain is they custom made the expander, and they. I'm in a call. Ilan, I'm in a call. Sorry about that. And Ilan, I'm in the phone. No, you can't talk to me right now. Sorry about that. There's a lab in Spain that custom makes the expander to the patient. So based on our prescription, we can actually custom make the expander and the screws.
Yes.
So it's not necessarily, something over the counter that we're going to adjust and just, solder it to bands in the teeth. It's especially designed for the patient. So the way Stanley does it, he actually does the dome going through the nose. So it's very minimal invasive because he doesn't even have to, cut inside the mouth. He was explaining that he goes in through the nose and he does all the cuts through the nose. So it's very, very fast.
The mini dome. Yeah.
The mini dome. Yeah. Yeah. And now with our expander that's custom made, it's just, and then going into Invisalign, it just becomes a procedure that's more gentle to the patient.
Absolutely.
And then after that, we set up the case, we get the expansion. Simon has designed a fantastic lower expander that actually adults can do very well with. That does, it's based on the contact resorption, not on teeth movement. So then you can set up the arches, and then they can actually feel comfortable going through a second procedure. Because back in the day, it was like having two Lefort ones, one to expand and the other one to advance. The patient didn't want to go through two projects. So the mini dome, or the Federico calls it Samarpe, which is a surgically assisted micro implant.
Samarpe,
yeah, the Samarpe. They're simple in-office procedures. They're not as expensive, and they're not as they don't have the morbidity that a full Lefort could have. And then the patient can feel he's being prepared to the big surgery of advancement.
Sandra had shared with me one of the videos of the procedure that Frederica had recorded, and if it's okay with her, I'll share it with the group as well.
It's in Spanish, but you can see it in real time. And you can see the custom-made expander too.
I would love to see that video, actually.
Yeah, so we'll share the link and have it downloadable for everyone.
Yeah, and Dr. Alfaro is perfectly fine with me sharing it.
Right.
Perry. Oh, your sound, Perry. Let me. Hello, Perry.
Can you hear me now?
Yep.
Yep. I've just got a few questions and a few comments. Great talk, Roland.
Thank you.
The first was with regards to the wafers you were using, because there are a number of sort of bone matrix preparations. There's some cadaver bony and cartilage preparations. I'm just wondering what you meant by that.
So, sorry, which one was this?
With the wafers, when you were acting, do you put anything between that, or do you just allow blood and fibrous tissue to?
Oh, okay. So it depends on the movement. Say, for example, maxilla coming down, there's obviously going to be a gap there. So that would require grafting. So there's different options for that. Oftentimes we're able to take some of the mandible, a sliver of the mandible, the outer cortex, and use that to interpose. But there's also products off the shelf which we can use as well. And we commonly use that with genioplasty. And so that's replaced with like bone grafting technique, sort of like creeping substitution. And that can maintain that position where there is a gap. So I hope that answers your question.
Do you find any are better than the others? Do you prefer autologous
tissue 100%? But there's other products on the market, made by various companies, like bone blocks. There's also in the US they use a lot of cadaveric bone. Yeah, it's only just starting to work its way into the Australian market, I think. There's like one supplier, I believe. And you probably know this as well for like, cartilage grafts and things. It's, a lot of cadaveric products are used overseas and but perhaps not so much in Australia.
It's just coming, it's just becoming available now.
Yes,
yeah. I just also wanted to make a mention, you showed an interesting case of a person with maxillary excess and where you disimpacted the maxilla. And the maxilla looked lovely, but the nose looked worse.
Yes, it did.
And I think this just highlights the multidisciplinary approach that we should all be taking here. Because 100%. I'm looking mainly at the nose and seeing the super expression and the alar widening, and but I'm looking at the maxilla and thinking, oh, that looks really nice. So so that was just my comment.
You're absolutely right. I mean, some of the movements with orthognathic surgery, there are certain ramifications for moving a maxilla forward as well as moving it up. And in her case, it was probably the biggest impaction I've done in my career. It was about 8 millimeters. Look, in hindsight, maybe we could have gone for a softer impaction, but certainly we did have the consultation with the patient saying that this could be an issue with your nasal widening. And certainly in units that I've worked in the UK, there were surgeons who did, rhinoplasty as well, and they would do a secondary procedure such as an alar reduction. But you're right, though. Certainly, it's good to get an ENT opinion, especially with these sort of cases. to make sure that she's got like a good functional airway, and we can maintain good tongue posture for her as well, and jaw strength.
Yeah, I think that I would say do what you have to do, and an ENT rhinoplasty surgeon can mop up what needs to be done to the nose later. And the corollary to that is that I sometimes see patients with, say, a bit of rosacea on their nose, and the dermatologist will just say to me, "Do what you have to do. I'll mop it all up once you're finished."
Right.
You know, occasionally when they're really bad, I insist on them getting some pre-treatment, and sometimes, you know, especially with acne.
Yes.
But again, I think it's the knowledge now that we are collaborative, and it's multidisciplinary, that I think is the key question, or the key point there. The other thing I wanted to make a mention of was you mentioned in one of your slides there was hemimandibular disproportion, and
yes.
I like how you were looking at the mandible, yet we talk in ENT terms about hemifacial microsomia. So we're looking at it from another perspective, that we're looking at faces, looking at their asymmetry and saying your nose can never be completely straight or never be completely symmetrical because your face is asymmetrical. So you were looking at it mainly from what am I going to do?
That wasn't a hemifacial microsomia case. That was a mandible elongation, and that sort of had a twisting effect on the maxilla and also the nose.
Yeah.
But yeah, you're right. Yeah, sure. Yeah, certainly worth having a wider perspective with looking at facial assessment.
And the other thing I wanted to mention was with the dome, what age are you actually doing that in? Because those upper incisors seem like they're getting really quite splayed.
Correct. Yeah, so these are in adult patients.
And do those teeth come back once they get orthodontics?
How do you mean?
So when you were doing the dome and you were transversely widening their
yes.
There was a big space between their upper incisors.
Yes, there is. And so what happens is that there's now a bridge of bone in between in the alveolar component. And there's a concept called regional acceleratory phenomenon. I'm not trying to bamboozle you, but basically following surgery with the bone, there's kind of like a cytokine effect, cytokines that influence the ability to move teeth within the alveolar envelope, if that makes sense. And so the orthodontist can actually move the teeth into the space that's created. Yeah.
Okay.
So basically, yep.
Yeah, I was going to say the other thing that I thought was interesting is that in the paper they were talking about the internal nasal valve rather than the external nasal valve, and they're
newspaper.
And it's interesting because strictly speaking, as you had mentioned with spreader grafts, is that the internal nasal valve is much higher than the area that you're operating on.
Yes, but at the same time, I think what the Stan Liu group was getting at was that it's increasing the base of that triangle, and that would have a ramification with that internal nasal valve angle, which would be, it might improve from say 12 to 15 following an aggressive dome where there is a expansion of a good centimeter in between in the nasal floor.
And the other thing I wanted to mention was that I think they probably need to get another acronym for MMA, because I keep on thinking of mixed martial arts, and you don't really want to have them conjoined as the likely outcome.
Yes, yes, perhaps that's a valid point.
I just think of cage fighting and
yes, I think if a patient was to Google MMA, that's probably what they would find out about.
Well, Roland is first and foremost a trauma surgeon, aren't you, Roland?
Oh, yes.
Well, I must say that one of the worst injuries I've ever seen in MMA was a guy who was kneed to the face and his entire nose got imploded between his eyes. And so I think that was a case of double MMA. I think he needed it both.
Indeed. You'll probably need to see both of us, right?
Exactly. But thank you.
All right, thanks, gents. We're a little bit over now, so let's just wrap up with a couple of last questions, I believe. If I'm Meadle had is, in your opinion, should we still be doing MAS? What was that reference to, Meadle?
I'm just referring to doing a mandibular advancement splints, given the success of MMA now, and really, you know, whether we should be treating mild sleep apnea in younger patients, it seems almost pointless in the absence of comorbidities, you know. So, yeah, just because you know, use of an MAS in long term can lead to the headgear effect as well. So, yeah, just wondered what your opinion was on that.
Well, certainly, you know, it's the range of options would need to be discussed with the patient, you know, as part of the informed consent process, and ultimately it's up to the patient to decide. We can't really sort of recommend one thing over the other. I mean, obviously, if it came to my office, I would have a, you know, a sort of bias towards surgical treatment, but well, certainly it's not for everybody, and there would be patients who would certainly elect and prefer to have mandibular advancement splint therapy over having the thought of having jaw surgery. So yeah, it depends on the patient, I would have thought, and the discussion with them.
But in terms of long-term outcome, surely MMA would be a better choice, right?
Yes, potentially, yes, in select patients. Yeah, ideally what we would want to see is a permanent solution. But obviously patients are more complex than that.
Sure.
There may be weight issues and so on that need to be addressed concurrently. So, you know, the contemporary approach for obstructive sleep apnea patients, as we all know, is a multidisciplinary one. So that's important to bear in mind.
Cool. Thank you.
All right, and the last question before we go to a break, I think it was Nathan, you had a question about what software is used for the planning?
The one I use is TrueMatch. Yes, that's one of the ones that I use. That's the name of it. But yeah, it's a very, very elegant software. I don't sort of do all the little movements myself, but the way it works is we sit down and have a planning session. And so we have someone who contacts us. We set up it's kind of like a Zoom chat, and we go through the planning together. Yeah. So there's different softwares available. There must be so many on the market by now.
All right, terrific. Well, thank you so much, Roland, for a terrific presentation. I'm sure
thank you can
rejoin later for Q&A, perhaps at the end of Perry's presentation. So let's take a break, guys. It's we've had a long session. We're going to take Simon. You think 10 minutes, or we'll be 5 minutes behind schedule if we take a 10-minute, or if we take a 5 minutes, we'll get started with Perry at 1:45. What is it? 2:45 as originally scheduled. You guys want a 10-minute or a 5-minute break, Simon? Simon's having a break right now. So on that note, thanks again, Roland, and we'll come back. Let's take a 10-minute break. We'll come back,
10 minutes.
Come back at 2:50 for Dr. Perry Burston. Looking forward to it. All right, thanks everyone.
Thank you.